Welcome to the lecture, Clinical Isokinetics. My name is Daniel Bodkin. I'm a physical therapist and athletic trainer. After spending time in the U.S. Army Field Artillery, I then went to the University of South Florida for my athletic training and physical therapy degree, where I graduated in 2012. I'm the owner of Proactive Athletic Performance in Atlanta, Georgia. I also work as adjunct faculty for the University of South Florida's Advanced Athletic Training Program. I'm an educational consultant for Computer Sports Medicine, or CSMI. And I had the pleasure of volunteering for the NFL Combine from 2013 through 2018, where I performed isokinetic testing. This lecture is broken up into 3 modules. In the first module, I'll discuss the science and theory of isokinetics. In Module 2, we'll go into testing, and in Module 3, we'll discuss interventions. The lecture objectives are to describe the theory underlying dynamometer testing and interventions, discuss research into the importance of performing dynamometer testing, demonstrate the various test types available on an electromechanical dynamometer, and demonstrate various interventions that can be performed on an electromechanical dynamometer. In this first section, I'm going to discuss the science behind isokinetic training and testing. This is a great slide that describes and demonstrates not only what we're trying to accomplish with the dynamometer, but also globally with our rehab. And that is, we're trying to restore our patients back to a normal or optimal state of health. For the dynamometer, we're focusing in on the muscles and tendons. And the key to any successful rehab program is to identify any weaklings a patient may have and then address them. And we can do both of those with an isokinetic dynamometer. Here's a slide that you're going to see throughout the course, and it highlights the basic roadmap of the course, but also a generic plan of care. For each major phase of the rehab, there's an application that can be used with the machine for your patient to address those weaklings and get them on to the next phase and back to function. To understand why we perform certain isokinetic tests or interventions, we first have to understand these 5 rehab concepts. Those are the modes of contraction, modes of exercise, speed of contraction, muscle strengthening, and neural adaptation. The first concept is the mode of contraction. Our muscles are only able to contract in 3 ways. In isometric contraction, there's no movement of the muscle or the joint angle. For a concentric contraction, the muscle contracts in the same direction as the change in the joint angle and the muscle shortens. In contrast, in eccentric contractions, the muscle contraction occurs in the opposite direction as the change in the joint angle and the muscle elongates. Why is this such an important concept? It's because we have to recognize that when an injury occurs, what is the mechanism of the injury? And more importantly, what is the mode of contraction that the injury occurred in? If you think about the examples that I have listed below, you'll find that with all of them, these injuries occur in the eccentric mode of contraction. In the picture on the right, the inversion ankle sprain that you see is an example of an eccentric failure of the fibularis muscles to control the ankle. So this is telling us already that by putting a focus on testing and training in the eccentric mode is going to be very important. Let's put together a chart where we compare the modes of contraction to something that we all know well, a car. For the isometric mode, in the body, it serves as a stabilizer of the joint or the body segment. It can protect the joint against excessive motion, or it creates rigidity of the joint, allowing for adjacent joints or segments to generate movement or force. In the example of a car, it acts as the suspension. Concentric contractions act as an accelerator in the body. It's what we use to raise our arm up to hang up a shirt or stand up from a chair. We can also use it in athletics to accelerate a ball or overcome gravity and jump up in the air. In the example of a car, it's the motor. We all want a strong, powerful motor. Now, traditionally in isokinetics, all exercise and testing is done in the concentric mode of contraction, getting that motor to become stronger and faster. For the eccentric mode, in our bodies, it serves as a decelerator. We use it to lower ourselves down the stairs or into a chair. We use it to catch ourselves from falling when we catch our toe on the carpet. Athletically, it slows our arm down after we release the ball, or it allows us to change directions when sprinting. In the car, it's the brakes. We generally do a good job of focusing on the eccentric mode during our closed kinetic exercise. But traditionally, when it comes to isokinetic strength training, it gets completely ignored as the concentric mode is used for reciprocal muscle actions. Now, at least the therapists who do this recognize the weak links in the chain, but when this happens, the patient's motor gets stronger and faster, but we're not matching that same volume of training on the eccentric mode. And a strong motor without adequate brakes leads to problems for our patients. Now let's look at each mode of contraction a little more in depth. For isometric contractions, with functional activity, we use these for joint stability. In rehab, we use isometric contractions for early muscle activation, improving joint stability, improving neuromuscular re-education, for tissue loading, and pain reduction. We can use isometric contractions at either a single angle or multiple angles. Remember that when you perform an isometric exercise, there is a training effect that carries over to 10 degrees on either side of that angle. So we can set our exercise angles up to 20-degree increments and still exercise the entire range of motion. Isometrics are also great for tendon loading and reducing pain, and we can do that with long hold heavy isometrics. The advantage of having a dynamometer is that you can accurately measure a person's maximal volitional contraction and then set targets for them to exercise at a given percentage of that maximum. On the concentric side, this is used for acceleration activities, such as throwing a ball, or for overcoming gravity, as with jumping. There is movement occurring here, as the myosin and actin ratchet together toward the center and the muscle shortens as it generates force. Eccentric contractions are primarily responsible for deceleration or for absorbing force, just like when you land from a jump. Here, the myosin and actin are still trying to ratchet toward their center, but because the external load is greater than the force created by the muscle, it elongates. Aside from the active components creating force, the passive structures in the system also contribute to force, and this includes the titin filaments within the sarcomere as well as the tendon. So this will allow some increased force production to occur simply from a mechanical aspect. Also, there's a different viscoelastic response from the muscle and tendon to loading. Now, there's also some very important differences between concentric and eccentric beyond the direction that the muscle is moving. First and most important is the difference in neurologic activity. Because the muscle and tendon are being stretched under load, the Golgi tendon organ and the muscle spindles are going to be excited. Just like with reflex testing, there's going to be a big neural contribution. So with this, you can get 2 to 3 times less EMG activity of the muscle during eccentric contraction compared to concentric when the load is matched. That basically means an improved neurologic efficiency. Also, we're going to stimulate our fast twitch muscle fibers at lighter loads. So when our patients are not able to exercise under heavy conditions due to injury or surgery, we can still engage those strength fibers early in the rehab process by focusing on eccentric loads. We're also going to have a superior enhancement in the power and plyometric effect by focusing on eccentrics, as that's what activates the stretch shortening cycle. Apart from the neurologic side, the muscle requires 70 to 75% less oxygen utilization for eccentric versus concentric when matched for load. All of these effects will result in about 30% greater force-producing capacity of the system eccentrically. The one downside to eccentric focus training is the amount of delayed onset muscle soreness that occurs. So during our other rehab exercises, including closed kinetic chain, we wouldn't have our patients focus only on the concentric contraction. So why are we doing this with our isokinetic machines? Again, the traditional isokinetic training has one muscle perform the concentric, and then its antagonist performs another concentric, bringing it back to the start position. So the eccentric mode is never used. But in this lecture, you're going to see how you can include the eccentric mode of contraction in both your testing and training applications. Now let's go back to the discussion on the mode of contraction during the mechanism of injury and combine it with the neurologic side. At the top of this slide, we have a stick figure doing a sprint, and we're going to focus on the leg with that thicker line. In this study, the authors looked at the EMG activity of different muscle groups during the sprint with each muscle in a different row. The portion that I circled is when the runner is decelerating the tibia to prepare for initial contact, and that's the dotted line going down. You can see that the glutes fire eccentrically first as they start decelerating the femur, and then the hamstring and adductors start firing eccentrically as they're slowing down the tibia as it nears full knee extension. This is where most hamstring injuries actually occur. Now, the hamstring stays active through stance phase as it helps extend the hip and propel the body forward concentrically. You can also see that the quadriceps kicks in highest just before initial contact to absorb knee flexion eccentrically. Here's a classic study by Job et al., and it's a great example for the shoulder. The phases of pitching are shown at the top of the slide with the EMG activity of each muscle across the bottom, and it's listed by phase of pitch. You can see that the maximum muscle EMG occurs at the follow-through phase when the shoulder is decelerating the arm after releasing the ball. This is where most of your rotator cuff strains are going to occur. Our second concept is the mode of exercise. The four modes of exercise are passive, isometric, isokinetic, and isotonic. Passive exercise is used right after surgery or injury for regaining range of motion, reducing pain and swelling. There's no patient input required as they completely relax and let something perform the motion for them. For isometric exercise, as we've already discussed, it's going to be used for early muscle activity to reduce atrophy, get neurologic activity to the muscle, as well as provide early controlled stress and strain to the system. There's the 10-degree carryover from the angle, and the patient only has to control the amount of force output. Unlike isometric exercise, during isokinetic exercise, there is movement occurring. The speed is constant, and the resistance accommodates to the patient. The patient only has two inputs they're responsible for, the amount of force output as well as the direction in which they're putting that force. In rehab, we use this for early neuromuscular control, beginning eccentric loading, strength training, and deceleration training. Now you can still perform the traditional isokinetic training, but hopefully after this course you can see its shortcomings. When we're talking about the mode of exercise, isokinetic is the best mode for strength training. At the extreme ends of the range of motion, the muscle is at a mechanical disadvantage due to the changes of lever arm as well as a reduced amount of cross-bridge formation in the sarcomere. But because the machine will accommodate the resistance to match the patient's level of effort, the muscle can be exercised at a maximum demand throughout the range of motion, so it eliminates any sticking points that can occur with traditional isotonic training. The graph on the left has force on the y-axis against the range of motion going across the x-axis. Now this is the typical torque curve for the quadriceps, with full extension on the left and full flexion on the right. You can see that as the knee starts in extension, the amount of torque the quad is able to produce is minimal, but as it nears mid-range, the force output increases until it peaks around 70 degrees before reducing as the knee moves toward full flexion. The graph on the right plots the percentage of muscle capacity on the y-axis with the same range of motion on the x-axis. You can see that because the resistance changes, the muscle gets exercised at the same level of intensity throughout the range of motion. This is going to contrast with what's coming up next with isotonic resistance. In isotonic exercise, the resistance is constant with the variable speed throughout the range of motion. The patient now has to control the torque or force output, the velocity, and direction. In rehab, this is used for strength training submaximally in the early phases and then maximally in the later phases. It's also used for endurance training, as you can lower the resistance and increase the repetitions. On the machine, we're going to show you how you can use the software to do both of these, but also in a way that significantly enhances neuromuscular control and proprioception. I'm also going to show you how you can use the machine for power training and rate of force production in the later phases of rehab. So with isotonic mode, the resistance is constant, but I put that in quotes because from the muscle's perspective, it's not. I told you earlier that the muscle has a mechanical disadvantage at end ranges, but it's strongest in the middle range. So when the resistance is held constant, the muscle has to work harder at certain points than others. So what happens is that in order for the patient to complete the full range of motion, the load has to be low enough for the weakest points to overcome it. If not, then you get sticking points and they have to compensate or cheat to get through the range. This slide shows the same graphs we saw with isokinetic, except for now they represent isotonic exercise. The graph on the left plots force along the y-axis with range of motion along the x-axis. Because the resistance is constant, the line is straight. The graph on the right plots percentage of muscle capacity along the y-axis and range of motion along the x-axis. At the beginning and end of the range of motion, where we're weakest, the muscles have to work harder to overcome the resistance, so the line is higher. But in the middle, where we're stronger, the muscles don't have to work very hard, so the percentage of muscle capacity is lower. So with traditional isotonic exercise, we're robbing our muscles of their ability to strengthen throughout the entire range of motion, as the stimulus for hypertrophy is not being met except for at end ranges. One more thing about isotonic versus isokinetic. This slide shows an ankle inversion isokinetic strength test. If we look at the graph on the right, this shows the eccentric strength curve. Now I put a line along the neutral ankle position for reference. The right ankle is in blue and the left is in red, so clearly the injured ankle is the right side, but that's not important for now. The curve to the left of the neutral line is eversion and the curve to the right is inversion. So you should notice that the everter muscle torque curve is much higher with the ankle in the inverted position when it's lengthened, and the line is much lower with it in the everted or shortened position. In fact, it's about twice as strong for this test. But let's think about how we traditionally isolate everters in rehab. Here I am with an elastic resistance on my left ankle working my everters. In the picture on the left, my ankle is inverted, but the band resistance is minimal. So if we flash back to the graph, you can see that's where my muscle is actually at strongest. In the picture on the right, I've now everted my ankle, pulling the band into maximal resistance for the range. But in this position, the everters are at their weakest point. And since we want our patients working the entire range of motion, we set the elastic resistance to match that weakest point. So bands are inexpensive, but they can't maximally strengthen the ankle muscles to the highest capacity like an accommodating resistance isokinetic exercise can. Moving on to our next concept. Concept 3 is the speed of contraction. If we look at this figure known as the force velocity curve, it gives us a lot of insight into how to manipulate the speeds of contraction to progress our patients and maximize our interventions. In the graph, the y-axis going up represents force output capability, so the higher up you go, the more force is being produced. The x-axis is velocity, with the middle vertical line being 0 or no motion, and velocity increasing as you go out both directions, left and right. The left side of the 0 line is an eccentric contraction where the muscle is lengthening, and the right side of the line is a concentric contraction with the muscle shortening. The point where the torque line meets the vertical y-axis represents an isometric contraction, as there's no movement occurring at that point. Now, the way this torque curve came to be is that if you take a patient and you test their muscle at both slower and faster concentric and eccentric contractions, as well as an isometric contraction, and you plot the maximum torque achieved on this graph, you get this line. So let's start with the contraction and speed with the lowest ability to produce torque. As it turns out, a faster concentric contraction produces the least amount of torque. The main reason for this is that you're using much of your strength just catching up to the speed of the dynamometer, and then what's left over gets pushed into the adapter arm and recorded as strength. As you move to a slower concentric speed, the muscle's ability to produce torque increases. It increases even further when you move to an isometric contraction. If you want to further increase the muscle's ability to produce torque, you have to then move to an eccentric contraction at lower speeds. And then as you go faster and faster in the eccentric mode, the more torque the muscle can produce. Now let's go back to traditional isokinetic training, which trains only the concentric mode. Many therapists will increase the speeds concentrically as their patient progresses, and they're doing it because they think they're working towards functional speeds. But as you can see with the graph, they're actually getting less muscle output as they do that. Now you're going to see that in this course, we're going to encourage you to utilize isometric and then eccentric contractions with increasing speeds as your patient progresses. Now, one thing to keep in mind, this force velocity curve is specific to isokinetic exercise, where the velocity is fixed and the resistance accommodates. In the isotonic force velocity curve, essentially we've just moved the eccentric and concentric to opposite sides. So to explain this, let's start on the isometric point on the graph. In the description, it's right in the middle of the slide. The example I want to use for this is the squat. So if I'm standing with the bar across my back just before I begin my squat, that's an isometric hold. If my bar weighs 225 pounds, then it's pushing down on me with 225 pounds, and I'm matching that amount and putting 225 pounds of force up into the bar. If we move to the right of the isometric point on the graph, that's slow eccentric lowering. So now say I'm only putting 210 pounds of force into the bar. So it's going to slowly overcome me and lower me to the floor. But let's say we go even further to the right of the graph, and now I'm lowering faster, and say I'm only giving 100 pounds of force into the bar. So you see, the less force I produce eccentrically, the faster I'll go. Now let's jump back to the isometric point. I'm now at the bottom of my squat, and I'm holding the bar, and I'm matching it at that 225 pounds. But if I want to raise myself back up, I have to push at least the weight of the bar's worth of force, and then some. So let's say I give it 230 pounds of force. So now I'm going to raise up concentrically but slowly. On the graph, that's moving just to the left of that isometric point. But if I want to accelerate it up faster, I have to give more force. If I give enough force to overcome both the weight of the bar and my body weight, then I'll jump. Back to our third concept of speed. As our patient progresses in their rehab, what are some of the ways that we typically progress them? Well, the first answer most people will give is, say, increase the weight or mass. Now, that's not a bad answer for sure. Well, if we think about what changes during functional activity and the reason behind doing some of our functional exercise progressions, we can see the why and the how and have it translate over to isokinetics. So during activity, the mass of the body and the ball doesn't change, but what does change is the acceleration or deceleration of the body or the ball. So that's what we're going to focus on with our dynamometer. If force is equal to mass times acceleration or deceleration for eccentric actions, so we can increase the force by manipulating the speeds. If we go back to the isokinetic force velocity curve, you'll remember that the faster we go eccentrically, the more force the patient will be able to produce. So we can start our patients off isometrically at the beginning and then start with slow eccentric loading, working the speeds faster as they progress. Now with isokinetics, another unique way we can progress the patient is by having them increase the percentage of effort they give. Since the machine accommodates, they can start off with minimal force production, say 25% effort. And as they progress, we can then increase to 50% effort, and then 75 or 75+% effort as the weeks pass. So we have a lot of different options available to us on isokinetic machines that you don't with the functional isotonic exercise. How can we standardize our speeds, and how can we define them? What makes a speed slow, moderate, or fast? Well, what we like to do is relate everything to the range of motion in which the exercise is occurring. For example, if we use knee flexion extension to exercise the quad, and we're exercising the patient from 10 degrees of extension to 90 degrees of flexion, that gives us a total range of motion of 80 degrees. So if we define our slow speeds as half or less of the total range of motion, so in this example of 80 degrees of motion, a slow speed would be 40 degrees per second or slower. A moderate speed is half the range of motion up to 2 times the range of motion. Our example here is from 40 degrees per second to 160 degrees per second. A fast speed is defined as 2 times the range of motion or faster. So here we're talking about 160 degrees per second or faster. Well, why does this matter? Well, when you have a joint with a big range of motion like the knee compared to a small joint with a smaller range of motion, such as ankle inversion and eversion, and you're only exercising them from 10 degrees of eversion to 30 degrees of inversion, well, that's only a total of 40 degrees. And it's half of what we're talking about with the knee. And when you have a smaller total range of motion, the speeds feel faster because the machine will change directions quickly once it gets to the end of the motion. So the actual speeds used will differ based on the joint when we talk about starting in slow and progressing to moderate or fast speeds. The fourth concept is muscle strengthening. When dealing with muscle strengthening, there are only a few concepts to focus on. If you can get these down, the rest of it is all in exercise selection and programming based on these principles. First is the SAID principle. That is, specific adaptations to impose demands. Basically, that means that you have to analyze the functional demands that the patient is going to encounter and match your program to meet or exceed those demands. Now, in the initial phases, we're trying to minimize tissue stress, allow tissue healing to occur, reduce atrophy, and promote neuromuscular learning. So those demands are a lot different than the endpoint. So the SAID principle changes as your patient's phases change. Now, when we move on to the next concept of neural adaptation, think back to the SAID principle, because if neuromuscular changes are your goal, you have to design your interventions around that goal. The next principle we're going to discuss is the overload principle, in which you have to manipulate the variables in order to overload the tissue and get it to respond and strengthen. As a student, John Hisamoto would always tell me to think of exercise as medicine, in which we're introducing an intervention to elicit a biological and mechanical change to the body. And we have to dose our interventions appropriately, just like we would with medicine. Too little and we don't get the change, but too much and we overdose them and we get adverse reactions. Now, we've already talked about ways to progress patients in general, but within any given exercise, we have to manipulate the resistance or the patient effort, if we're talking isokinetics, the number of repetitions, the rate of loading or speeds of exercise, as well as the exercise duration or time under tension. When discussing muscle strengthening, we have to talk about the difference between type 1 and type 2 muscle fibers. Type 1 are smaller, with less fibers per motor unit and a slower contraction speed. They produce less force, but they're also resistant to fatigue. We typically recruit these first when exercising or performing tasks, and it's our primary fiber for sustained or endurance activity. Type 2, on the other hand, are larger, have more fibers per motor unit, and have a faster contraction speed. They produce more force, but they fatigue easily. And we only use these fibers when the load of the exercise or task is heavier than what the type 1 fibers can handle, so they're recruited last as the difficulty increases. Now, typically, they're also used for brief or intense activity, but here's the thing. We need to get to our type 2 fibers in order to increase strength. But if our patients have injuries or they can't exercise with heavy resistance, then how are we going to get to those fibers and get strengthening to increase? And you'll see we have a few ways to get these fibers going at lighter loads earlier in the rehab. Now that brings me to the final concept I'll cover in this section, and that's neurologic adaptation. When it comes to designing our rehab plan of care, we need to put a major focus on the neurologic aspects. Now, I just discussed the difference between type 1 and type 2 muscle fibers, and I mentioned that we only engage our type 2 strength fibers at higher force requirements. We only get to these fibers as the resistance increases, but there are a few ways to activate them earlier on. The first is during eccentric contraction. During eccentrics, there's a preferential recruitment of type 2 fibers over type 1. The other way we kick in our type 2 fibers at low resistance levels is with blood flow restriction training. And there's multiple ways that you can combine blood flow restriction training with the dynamometer to use throughout the rehab process. When we get neurologic adaptation from strength training, it occurs through two main mechanisms, spatial and temporal summation. Spatial summation is where there's an increase in the number of motor units that fire when you perform a task or exercise. Once this adaptation occurs, for the same exercise load, you get more motor units firing, so the number of muscle fibers involved will also be increased. The second mechanism, temporal summation, is when the frequency of firing to those motor units is increased. So when both occur, there's now more total units firing, and they're firing faster, leading to increased strength. This takes place in the first 6 to 8 weeks of training. And let's tie this back to our last concept of muscle strengthening in the SAID principle. I can train a certain way for 6 to 8 weeks and get neurologic adaptation to that specific training type. But if I then switch the stimulus in training type, then we get the neurologic system. It's going to make more adaptations to that new type of training. Like I said earlier, the eccentric mode of contraction has a different neurologic mechanism in place. And the eccentric mode is responsible for the stretch shortening cycle or plyometric effect, which is paramount for returning to athletic activity. So if a person doesn't train with the focus in the eccentric mode, they won't have made those adaptations by the time they reach their plyometric and agility portions of their training. In fact, the muscles will actually shut down neurologically when they're stressed to plyometric activity if they've not been trained for it. So this will lead them to make movement compensations, which can cause them to lose performance in their sport or re-injure themselves. So let's take the example of the quadriceps after ACL reconstruction. The muscle that atrophies away is the quadriceps, and it's going to be responsible for controlling sagittal plane knee flexion. If we can isolate that weak link in the eccentric mode and get those neurologic adaptations to occur before we get them into their dynamic sports activity, then they're not going to be making those movement compensations that can be harmful, and their transition to later phase rehab will be much smoother. If we take the example of the rotator cuff with our throwing athletes, since the external rotator decelerates the arm eccentrically after throwing, we can improve their success of getting into their throwing programs and returning to sports by addressing the eccentric mode for those external rotators well before they get back into throwing. Here's an older study by Kim and Kramer in which they looked at using visual feedback during isokinetic quadriceps testing. Half of the 40 healthy subjects, both male and female, were provided with visual feedback, and they had higher torque production in both concentric and eccentric contractions compared to the subjects without visual feedback. The authors also discussed how the eccentric contractions were more responsive to visual feedback, and they relate this back to the mechanisms such as preferential recruitment of type 2 muscle fibers, the muscle spindle stimulation, and the cross-bridging kinetics during eccentric contractions. This is a study that was performed out of Japan in 2018, in which they took 12 young, physically active, yet untrained males. They trained the quadriceps muscles twice a week for 10 weeks on an isokinetic machine, with one leg performing only eccentric contraction and the other leg performing only concentric contractions. The eccentric leg was done first for up to 6 sets of 10 reps, and then the concentric leg performed enough reps in each set to match the total amount of work in the first leg. They measured them with MRI for changes in cross-sectional area as well as EMG testing. They also tracked the exercise over the 10 weeks for changes in peak torques, work, and fatigue. They found that training in the eccentric mode of contraction on an isokinetic machine resulted in greater increases in strength, neural adaptation, and hypertrophic changes compared to concentric-only training when matched for total work. So again, make sure to focus on eccentric loading with your isokinetic exercises. Now, once these adaptations occur and that neurologic system is running at full steam, then you get into the muscle hypertrophy phase of strengthening, and this typically occurs after 6 to 8 weeks of training. One last discussion point in this module before we move on is that I get asked all the time whether open chain knee extension is safe to perform after ACL reconstruction. And the answer is yes, it is safe when it's done at the right time, when it's done with the appropriate setup, and when you limit the torque load. This graph shows a strain on the ACL with open chain knee extension, and along the y-axis going up is the load on the ACL in newtons. Along the x-axis, you see different figures, and that represents a leg in the sitting position, and the little arrow shows you where the pad is placed on the tibia. So to start on the left, the pad is proximal, and the further to the right you go, the pad gets more and more distal. Each line on the graph shows you the amount of load on the ACL when the knee extension is performed at different angles. So the top line on the y-axis is 0 degrees, then 15 degrees, then 30 degrees, 45, and 60 degrees. And you should notice that the more extended the knee is, the more torque the ACL gets. And you should also see that as the lines travel across to the right of the graph, they get higher and higher. And that tells us that the more distally placed the pad is on the tibia, the more stress that's on the ACL because of the anterior shearing that occurs. So this study found that at 90 degrees, you have the least strain on the ACL, but it increases as you move toward extension. But if we look at if you put the pad in the middle third of the tibia, which is where I highlighted in blue on the screen, the loads are typically half that of the distal pad placement, which is the red highlighted area. If we look at just the 30-degree line, you can see a 200 Newton load on the ACL when the pad is placed in the middle of the shin versus 400 Newtons with the distal pad. And keep in mind that the native ACL can withstand up to 2,000 Newtons for context. For comparison, when you walk, every step you take, you engage the quadriceps at heel strike, which keep in mind that's a closed chain position. The ACL is getting a 300 Newton load. And we don't tell our ACL reconstruction patients not to walk, right? We typically have them walking without crutches and even out of their braces around household distances between weeks 4 and 6. So again, if we start doing open chain extension at the right time, with the appropriate setup, with the appropriate exercise application, and under appropriate loads, then it's absolutely safe for this population. And I'd even go so far as to say it's essential not to delay isolating the quad. Now that we've learned the concepts behind isokinetics, let's now go into how you can use it with your patients throughout the entire plan of care.